reason for doing the study is that we base our practice of thromboprophylaxis in medical patients on older studies that mainly used asymptomatic outcomes as their primary outcome event. And that raised criticism because and uncertainties about the risk-benefit balance because of also the risk of major bleedings that is associated with the use of anticoagulants. We've been asked to use clinical decision score or risk assessment models to risk stratify patients, but they are complex, hard to implement in clinical practice, and to be honest, poorly used in hospital even these days. So we decided to get rid of that and to start back from scratch and to do a placebo-controlled clinical trial using enoxaparin again, which has been the standard of care for many years. And instead of using complex risk assessment model to target a high-risk population, namely older adults, and not restricting on any level of immobilization or comorbidities or reasons for admission, any of that. So they were plainly randomized to either getting a placebo or enoxaparin 40 milligram daily for 6 to 14 days, which is again accepted practice. Primary outcome was a risk of symptomatic VTE at day 30, but we continue to follow this patient up to day 90. The primary outcome was disappointingly negative, not showing a significant benefit of enoxaparin versus placebo. The problem with that is that the study was underpowered because the pandemics kicked in, and at some point we couldn't secure more supply of enoxaparin to be able to complete the study. So we had to stop after we only had 70% of the expected number of outcome events during follow-up. That being said, negative results, so you could see the glass half empty, you could see the glass half full. When you look at the day 90 outcomes, there seems to be a trend towards less recurrent VTE, particularly less pulmonary embolism at day 90, and it's a 1% absolute risk difference, which makes us think that it's too early likely to throw the baby with the bathwater, and that we should do more studies, maybe adjusting the follow-up window to 90 days, and maybe refining again risk prediction even in elderly patients so that we can get an optimized thromboprophylaxis for our medical patients.